Hi guys, today we will be discussing yet another tumor in the head and neck region, which is very important from the ENT point of view because a lot of questions are being asked. Even though rare, it is a tumor which can be seen occasionally and which is operated in tertiary care centers occasionally. And this is the most common benign tumor of the mid-layer, and yes, it is none other than the glomus tumor. The terminology glomus, you might be familiar with another thing, but is that the arteriovenous malformation of the pulp of fingers, right? No, I'm not going to talk about that. I'll be talking about the paraganglioma of the jugular bulb and the paraganglioma in the region of the tympanic plexus. These paragangliomas are actually derived from the neural crest and hence can be seen in any region in the figure as seen. And so you might be familiar with another paraganglioma. What is that? Yes, the catecholamine releasing paraganglioma, which is associated with headache, hypertension. What is that? Yes, it is nothing but pheochromocytoma of the adrenal medulla, right? But there is a difference between that paraganglioma and the paraganglioma that is seen here in ENT. What is the difference? Here the difference is that the patient will have no such symptoms of hypertension, palpitations, etc. because the paraganglioma here is a non-secreting paraganglioma. It is having the non-chromaffin cells, unlike the pheochromocytoma where there are the chromaffin cells. Okay, so today we are going to discuss about the most common benign tumor of the mid-layer, and that is what is known as the glomus tumor. Okay, now what are the features of glomus tumor? Again, first of all, I told you it is the most common benign tumor, and since it is a benign tumor, it is having no chance of metastasis or lymph node mets, anything like that won't happen, but it is locally invasive even though encapsulated. It is an encapsulated tumor, but it is locally invasive. It is derived from the neural crest. Okay, it is a paraganglioma, and yes, it is seen in association with nerves. Okay, where there are plexus of nerves, there it will be seen. That is why it is most commonly seen in the area of the tympanic plexus and in the area of the jugular bulb. Okay, and what are these known as? They are called as the glomus tympanicum and the glomus jugulaire respectively, and it is most commonly seen in women for some reasons which we don't know yet. It is seen in the ratio of 5:1, female is to male. In some books it even mentioned as 6:1. Okay, so these are the features of the glomus tumor that we are discussing now. And yes, this is the glomus jugulaire, which is the more common variety, and glomus jugulaire, as you can see here, it arises in the region of the jugular bulb. Okay, you can see the jugular bulb here, and in that region you have the 9 and 10 cranial nerves. Okay, and the auricular branch of vagus rises in this region, and also the tympanic branch of the glossopharyngeal nerve, the Jacobson's nerve, which goes on to supply the promontories, also arising from here. Okay, so these nerves have these neural crest derivative from which it develops. Okay, so this tumor, what is the presentation of this tumor? The patient will present with a conductive hearing loss. Patient will have a pulsatile tinnitus, and on examination you will have a conductive hearing loss. Now, what are the features of conductive hearing loss when you are doing a Weber's test, it will be lateralized to the same side, and the Rennie's test will be negative on that side, and the ABC will remain normal, and the Schwabach test will be lengthened, isn't it? Why is it showing a conductive hearing loss? Because it will be filling the middle ear, so there will be a conduction problem. Sometimes the patient will present with bloody ear discharge, and on examination you will be seeing a polyp there, okay, polyp. And when you take a biopsy from that area, you might get this typical cell balance pattern. Cell balance pattern is associated with the neuroendocrine tumors like these paragangliomas. They have this typical cell balance pattern. Okay, it is also seen in pheochromocytoma. Even in the carotid body tumor also it can be seen. Okay, so this is a non-chromaffin tumor, that is, it won't be stained by chromaffin because it does not secrete the various catecholamines. Okay, but rarely it can secrete catecholamines because in some cases it might be due to the tumor itself that it is secreting the catecholamines, and because it is multicentric, in a patient who is having this glomus tumor, he might have an associated secretory tumor elsewhere. It might be a pheochromocytoma itself, and that might be the cause of increased urinary VMA. Okay, so what is the test to rule out a secretory tumor? You have to look for the urinary VMA. Okay, so whenever you are going to do a surgery for this patient, you have to check for urinary VMA to rule out a pheochromocytoma, or else when you are going to do a surgery, it might be catastrophic. There will be uncontrolled hypertension. Okay, now coming to the presentation of glomus tumor, I told you patient presents with a conductive hearing loss, and he will have a bleeding polyp at times, and sometimes when you look at the patient you will be able to see a red color. Okay, and it might resemble a sun which is rising or a sun which is setting, and that is what is known as the rising sun sign or the red reflex. Okay, rising sun sign or red reflex is seen in a case of glomus tumor. Okay, so that is what you see when you are examining the patient. Okay, so this is the typical appearance of the rising sun sign or the red reflex. Now how will you differentiate it from an acute otitis media where there will be redness of the tympanic membrane? In acute otitis media it will be generalized redness and congestion. Unlike the acute otitis media, what you see here is the tumor seen in the inferior part, which is giving the red color to the tympanic membrane. Okay, so that is a different scenario here, right? And this is the rising sun sign. Okay, now what are the other signs that are seen? Who is this guy? He is none other than Dan Brown. Okay, Dan Brown, he is famous for his Da Vinci Code, right? Now I am not going to talk about Dan Brown. I am talking about the Brown sign. Okay, Brown sign. What is this Brown sign? When you are using a Siegel speculum which is attached to the external aortic canal, and when you increase the pressure in the external aortic canal, what happens is that there will be blanching of the tumor. Okay, this blanching of the tumor will be associated with the decrease in the pulsatile tinnitus, and this is what is known as the Brown sign. And along with the Brown sign, another sign that can be elicited is the Equinox sign. Who is this guy? He is none other than Michael Phelps, right? Michael Phelps. There is one sign called Phelps sign, okay, about which I'll be dealing with shortly. But for now, let's concentrate on the water he is swimming. Water stands for aqua, right? So there is equinox sign here. In equinox sign, what you are doing is you are compressing the external carotid artery, okay, and by compressing the external carotid artery and the common carotid artery area, you are trying to decrease the transmitted pulsation on the glomus tumor, okay, and with that there will be a decrease in the pulsatile tenosis. That is what is known as the equinox sign. So you have to auscultate for that, okay, whenever you are seeing a patient. So the patient will have a pulsatile tinnitus and present to you in the OPD, and on examination you will be able to find that the patient is having conductive hearing loss. When you auscultate, you will be able to appreciate the pulsatile tinnitus better. The specialty of this tinnitus here is that it is an objective tinnitus, so you are also able to find that tinnitus, okay. When it is subjective tinnitus, only the patient will be able to hear, and here you are able to not just appreciate the tinnitus but also find that the tinnitus is synchronous with the pulsation. That is why it's called as a pulsatile tinnitus, okay. And there are other causes of tinnitus like the neuromuscular causes, where you have a palatal myoclonus or a myoclonus of the tensor tympani. All these can also present with objective tinnitus. There are only few causes of objective tinnitus, and that you have to know. The subjective tinnitus, it can be due to a lot of causes, okay, multiple causes, but objective tinnitus are only few causes. And yes, only in glomus tumor, by compression of the carotid, you are able to have the tinnitus decreased, okay. So that is what is known as the equinox sign. And then you have to elicit the brown sign by using a Siegel speculum, and also you have to look for a red reflex or a rising sun sign. Now, how does this glomus tumor spread? It spreads medially into the inner ear. Laterally, it spreads into the external aortic canal, and it forms a bleeding polyp. Now, whenever you see a polyp in the external aortic canal, it is advised not to avulse it, because it might be attached to the facial nerve. That is one reason. Another reason is it can be a glomus tumor like this, okay. So that is another reason why you should not avulse a polyp in the inner ear, in the external canal, okay. Now, what are the other things that can happen? It can spread medially, laterally. From the middle ear, it can go downwards, right? Downwards, when it goes through the floor, where can it go? It can invade the 9, 10, 11 cranial nerves, okay. 9, 10, 11 cranial nerve involvement can result in dysphagia, dysarthria. All those problems can arise because of the 9, 10, 11 cranial nerve involvement. And whereas it can spread, posterior spread can occur into the mastoid and can involve the facial nerve, okay. Facial nerve may be involved. So one of the presentation is a multiple cranial nerve palsy, but this occurs late. Before that, the patient will have the pulsatile tinnitus and even the ear bleed, okay. All these things occur initially, and multiple cranial palsy usually occurs late, okay. So this is how a patient having glomus tumor presents to you, and then what are the investigations that you have to do? I already told you will have to do a urinary VMA if you are planning for surgery to rule out if it is a catecholamine secreting. What have you learned about pheochromocytoma? You have learned that 10% are having a secretory pheochromocytoma, right? But here it is even more rarer. And yes, in patients who have a glomus tumor suspected, the investigation of choice is a CECT, contrast enhanced CT, Why? Because between the carotid artery, internal carotid artery you see here, and between the jugular bulb there is a crust of bone. Okay, that crust of bone will be invaded by the tumor, and that can result in the crust of bone between jugular bulb and the carotid eroded and lost, and this is one sign which can be appreciated, and that is what is known as the Phelps sign. Now, why is it contrast sensitivity that we are doing?